welcome to my small talk. I am Vince. I'm a PGY-2 EM resident, if we haven't met yet. Shout outs to the small talks team listed here. So our case starts off with a 27-year-old male, history of alcohol abuse, never withdrew in the past. He came in for anxiety that started last night, was daily user of about 1 liter of tequila, last drink unknown, stopped drinking because his dad died recently. Otherwise, review systems was negative. Here's your vitals. There's your finger stick, little tacky, little hypertensive. Otherwise looks okay. You finally go and see the patient. This is what he looks like. Here's his hands. He actually has full body Geigers. I couldn't find a GIF that showed that, but here's the hands. So what do you do? Right? Seems like the highest thing on my differential was alcohol withdrawal. He was otherwise healthy. So I gave him some Valium, right? Start off with 10, upped it to 20, gave another 40, and he was actually stable. Asymptomatic at this point. Everything had come down. His labs were otherwise unremarkable. I think his alcohol level was in the 100s. I called the ICU guys just to kind of get the rejection, just so medicine would say okay. The ICU guys laughed at me, told me to call back when I was over 200 of Valium. Medicine accepted the patient. However, 1 hour later, medicine finally shows up to see the patient. This is how he looks. He went right back into it. Right. And so why did this happen? There's a subset of our population that has quote unquote resistant alcohol withdrawal, otherwise known as benzo non-responders. So this patient actually was, I presume, one of them, because he ended up getting an additional 200 plus milligrams of Valium, 390 milligrams of Phenobarb, was intubated, placed on a Precedex and a propofol drip, and eventually admitted to the ICU. So my small talk today is actually going to be on Phenobarb. Hopefully one depressant to rule them all for all my Lord of the Rings fans. Here's my learning objectives. So we're going to do a brief, literally 1 slide pathophys of alcohol withdrawal, benefits, contraindications to using Phenobarb, pharmacokinetics, and pharmacodynamics, as well as finally ending with dosing. So this was taken from the Internet Book of Critical Care, which is a subsect of MCRIT, if you guys haven't heard about it. So here's the neurochemistry of alcohol withdrawal, right? So how does it work? Basically, when you're non-alcoholic, your GABA levels and your glutamate levels are at homeostasis, at baseline. When you add in alcohol, you actually essentially have a less of glutamate. And so once you become a chronic user, your glutamate levels get upregulated through the AMPA receptors, also NMDA receptors as well. When you are a chronic alcohol user without any alcohol, you now have upregulated glutamate in your system. That's what causes all the autonomic changes. That's what causes, the shaking, the fasciculations. Standard treatment of benzos usually only gets the GABA receptors, right? And now with Phenobarb, you get both GABA interaction as well as glutamate interaction. So Phenobarb actually hits 2 facets of alcohol withdrawal versus benzos only address 1. So benefits of Phenobarb: works with benzo so-called non-responders, has a ridiculously long half-life. The pharmacokinetics and dynamics are actually very, very predictable. It's all straightforward math, no logarithmic algorithms needed. Causes decreased ICU admissions as well as decreased ED bounce backs. So here are some studies. Okay, so in this study, there were 19 patients who got more than 50 milligrams of IV Valium in the first hour they were followed. 15 of them required more Valium, 14 required barbiturates, 7 were intubated. Here is another study with 184 patients, but they had similar findings where there was a large population that did not respond to benzos right away. In this very interesting case report from 1979, there's a 33-year-old alcohol user who got a total of 2.3 grams of Valium over 7 days, but it barely touches symptoms. What they found was that they measured the concentrations, all the metabolites in his body, And they were adequate. It shows that, he was actually metabolizing it. It just might have been due to like a receptor phenomenon, hence leading further into this idea that there's a population of benzo non-responders. This was a study out in California that looked at a alcohol withdrawal protocol that utilized just Ativan versus Ativan plus a single dose of phenobarb. What they found was they had a decreased ICU admissions when phenobarb was added. It was 8% versus 25%. And this final study showed that treatment of alcohol withdrawal symptoms with phenobarb, adding a benzo did not make a difference. It was the phenobarb that showed a significantly lower odds of bounce back ED visits within 3 days, right? So it sounds all great, but why is your attending going to refuse to use it, right? Number one, are they pregnant? Could they be pregnant, right? Number two, do they have advanced cirrhosis? If you give someone in hepatic encephalopathy some phenobarb, they're going to be snowed for absolute days, right? They have porphyria, so this one very, very rare disease from step one that no one has ever seen before, right? It can induce attacks, so make sure you stand them outside in the sun to make sure that they don't have porphyria first. If they have prior phenobarb use, you have to reduce or lower the loading dose, mainly because you have no idea how much phenobarb they have in their body already. Same thing with multiple sedating meds or other neuro issues. So if there's any possibility that they could have some type of other issue going on, you don't want to give them phenobarb because, again, you're going to snow them for days and you won't have any idea. Finally, you want to make sure there's no drug interaction. So phenobarb gets metabolized through the CYP system. So if there's anything, especially like HIV medications, really any antiretrovirals, you're going to be looking at a lot of complications. So here's a graph that shows comparison of phenobarb via IV and the onset of action compared to some of our most common other benzos. This is a graph that shows the half-life. Now, some of the half-lives of these benzos were of their metabolites, and they were also ranges. So I just took the longest range. Phenobarb, this was the greatest range of 118 hours. Okay, this previous graph, this was measured in minutes. This one's in hours, right? So clearly, phenobarb takes the win here. This study showed that there is a linear relationship between phenobarb dose and total body concentration. Now, this is in males. This graph is in females. Now, why is this important? Because now going into pharmacokinetics and pharmacodynamics, we can then understand why phenobarb is actually just straight up math, okay? So there's something from pharmacokinetics, if you can recall, volume of distribution. So the formula is total body concentration divided by plasma concentration. Now, how can we use this? So we actually know the volume of distribution based on studies, animal and human studies. The volume of distribution in phenobarb is actually 0.6 liters per kg. What that comes out to when doing the math is actually to calculate your total body concentration, it is approximately 1.5 times the dose in milligrams per kilogram. These numbers are kind of arbitrary at the moment, but just remember 10 milligrams per kilogram is equal to approximately a total body concentration of 15 micrograms per milliliter. 40 milligrams per kilo is equal to about 60 micrograms per milliliter. This is another table stolen from Internet Book of Critical Care. And what this shows is that there actually is not really good evidence for an established range of total body concentration of phenobarb. However, what they have found is that in epilepsy trials, the therapeutic range is about 15 to 40. In some other also epilepsy trials, they found that severe toxicity occurs at greater than 65 micrograms per milliliter. So what does this mean for us? Well, if we want to stay below definitely below the 65 micrograms per milliliter, we want to stay below 40 mg per kg dosing. But if we want this to be closer to epilepsy and you're not in treating epilepsy and not like absolutely snowing them completely, we actually want to stay realistically below this like 40/30 micrograms per milliliter, which means we want to stay between this 10 to 20 milligrams per kilogram dosing, right? So stay with me here. So MGH actually did a comparison of they had a phenobarb protocol versus like a benzo protocol for alcohol withdrawal. This was a retrospective chart analysis, which actually showed similar outcomes in using phenobarb versus benzos. Their primary outcome was actually just any type of symptoms refractory to treatment initiation. So basically, if the patient started seizing, had alcoholic hallucinosis, or they were in DTs, that was an abnormal finding. So what we can take away here is that the phenobarb protocol didn't show any difference in benzos, but even at the highest doses, what they were looking at was actually 15 mg per kg. So that average total body concentration would actually be 22.5 micrograms per milliliter, which again is below our way below our toxic dose of 40 or even 65 micrograms per milliliter. So now that we know how much to dose, how often do we dose it? Here's a study that shows that cumulative phenobarb dose where cumulative phenobarb dose and total body concentrations were similar, but they separated them into front loading versus intermittent dosing. What they found was front loading doses showed a significantly lower incidence of needing to get intubated. So there's actually 28% versus 63%. So all in all, what does this mean? Right? How do we decide if someone is a candidate for a phenobarb or not? So our friends at the Internet Book of Critical Care, I will continue to reference them. They came up with this great chart. So we'll break it down. So first one is, are they a candidate for phenobarb in general, right? So the guys at IBCC, they focus on phenobarb monotherapy, right? So their goal is just give everyone who's uncomplicated alcohol withdrawal phenobarb so that they don't withdraw over the next like 3 to 4 days, right? But so if they do qualify for this, then you'd consider, okay, do they do a loading dose or do we do intermittent dosing, right? If they have no other neuro issues, you think they're otherwise healthy, they don't take phenobarb, they don't have anything else going on, you can give them the loading dose. Otherwise, if they've already gotten some benzos, if they maybe were involved in trauma, you should consider either doing the intermittent dosing or not giving phenobarb at all. Next step, monitor the cumulative dosing. Now, I disagree with this rough estimate of the serum levels. I think they're being a little bit liberal here because based on like, regardless of how you do the math, it's actually 20 mg per kg comes closer to about 30, even 35 micrograms per milliliter. Now, yes, we can send off phenobarb levels and they do come back. They are processed at our lab. But this takes time. And when someone's critically ill, sometimes you just need to kind of estimate quickly at bedside to decide if you want to give an extra dose or not. Finally, if you're really approaching this 20 mg per kg or even 30 mg per kg, you should really stop and consider something called a NARD, right? Otherwise known as a non-alcohol related delirium. So just consider broadening your differential. So finally, picture's worth 1,000 words, unless it's a picture of 1,000 words. This is the entire whole, table that they want to use. Here's the takeaways. Phenobarb can be used as monotherapy for uncomplicated alcohol withdrawal, preferably front loading because it reduces need for intubation. Monitor total body concentration. The rough estimate is 1.5 times the dose in mg per kg. And consider broadening your differential if you're getting near the toxic concentrations. Here are my references, and that is it. Any questions?